السلام عليكم أعزائي الطلبة، وأمنياتي لكم بالصحة والعافية والسعادة الدائمة. Today I will talk about an important subject, jaundice, defined as a yellowish discoloration of sclera. This part of the body is rich with elastin, fibrous tissue, and has an affinity to attract the bilirubin, which is normal level is from 0.3 milligram to 1 milligram per deciliter normally. This is a normal subject. Above this level, consider jaundice, and can be revealed clinically when the level reach about 3 milligram per deciliter. So, from where come the bilirubin to become a pathological process and can be seen as a jaundice? Normally, the RBC is biconcave in shape. Its own life 90 to 120 days. When in the end of the life, phagocytized and lysed by the phagocyte into the endoarticular system, namely the spleen, which is the end or symmetry of the RBC, into two components, heme and globin. This is a protein, amino acid, into amino acid pool, and this go for ferret and bilirubin. This type of bilirubin or a fraction is the unconjugated bilirubin. The other name is indirect bilirubin. By using albumin protein as a carrier, it will be uptake by the liver, and in hepatocyte the process of conjugation will take place by conjugation with the glucuronic acid and become conjugated bilirubin. This is water-soluble fraction, and this is fat-soluble fraction, revealed in and excreted in urine because it is water-soluble to the kidney, and this is cannot be excreted through the kidney because it is fat-soluble fraction. This is the normal pathway, and this happens extravascularly. If abnormal shaped RBC present in cases of hereditary diseases, for example, hereditary spherocytosis, in which the shape of the cell is spherical. If it is lodged into a small capillary, it will be distracted intravascularly. Over-destruction of RBC, abnormal RBC, called hemolytic anemia. So it is anemia, I mean low level of hemoglobin, the presentation of this case, beside the component of the hemoglobin, bilirubin overproduction, which is the prehepatic type of jaundice. This is first type, prehepatic jaundice, due to over destruction of RBC due to hereditary abnormality. Other type can take place due to liver parenchymal disease. For example, hepatitis, viral hepatitis A, B, C, E, D, or fungal or bacterial infection, or tumor like hepatocellular carcinoma or hematoma. These are other type, or due to alcoholic cirrhosis. This is other type of disturbance of the function of liver and lead to hepatic or hepatocellular jaundice. The other type, which is concerned mainly by surgical specialty, or called post-hepatic or obstructive type of jaundice. This is occur due to obstruction of biliary tree, whether right or left biliary hepatic duct, common hepatic duct, or common viral duct. The obstruction occurs usually due to an obstructive agent for these trees, either luminal, and the main cause, common cause, is the gallstone. Formation of gallstone slipping into the cystic duct impacted here lead to the increased dilatation of the hepatobiliary ducts and backflow and destruction, even the liver, or neural cause due to inflammatory condition involving the wall, whether or structure, whether benign structure like primary sclerosing cholangitis, or due to malignant cause, cholangiocarcinoma, or extramural or extraluminal cause, pressure effect on the wall of CBD, like carcinoma of head of pancreas, or enlargement of lymphatic gland due to tumor or reactionary, or due to impaction of the gallstone into the Hartmann and the pressure effect, and this we call it Merezi syndrome, or due to other compression or causes of compression of the biliary ducts. This is called post-hepatic or obstructive type of jaundice. Now we go how to can differentiate between the three types. First of all, by history and examination. Clinical history should be asked about the chronicity of the jaundice. Is it acute? Is it a chronic duration of jaundice? Presence or absence of pruritus, scratch, and pruritus mean deposition of bile salt into the skin and irritation of the nerve ending responsible for itching. Painful or paleness, presence of yellowish discoloration of urine. Key colored urine indicate an obstructive type, and the passage of conjugated or direct bilirubin through the kidney due to obstructive type. Clay-colored stool indicate an obstruction also for the biliary tree. These things should be considered when taking a history. The other thing is presence or absence of cachexia, weight loss, fever. All these things also important. Investigation done, starting with a simple complete blood count. Hemoglobin low and platelets count high involves destruction, and compensatory mechanism for destruction of RBC may be in cases of hemolytic disease. Total serum bilirubin should be requested, and its a fraction, direct and indirect. Elevation of TSV in jaundice, direct in case of obstructive, and indirect in case of prehepatic. Virology. Screening, hepatitis B surface antigen and anti-C antibody, also important. Enzymes, SGOT, SGBT, alkaline phosphatase. These are the enzyme of the liver tissue, produced by liver tissue, and when there is a disease process involved the liver, usually this enzyme will be elevated. And the alkaline phosphatase can be produced from different side, but from the epithelial lining the biliary tree, extrahepatic biliary tree, and when there is an obstruction, there will be elevation of the alkaline phosphatase to indicate an obstructive process. Ultrasonography, also another tool available, non-invasive, and can be done to assess the status of the liver, congestion, presence or absence of filling defect, dilatation of the biliary system, presence or absence of the stone, and is very sensitive, even better than CT, in discovering the gallstone. Other is MRCP, magnetic resonance cholangopancreatography, to assess the status and the presence of any gallstone in the common bile duct, and is a non-invasive method also. ERCP, diagnostic and therapeutic, to assess the common bile duct and hepatic ducts by pushing a dye to be seen, and the cleaving of a stone, sometimes impact the stone in the common bile duct, and doing sphincterotomy and putting a stent, metallic or a plastic stent, to ensure the patency and flow of the bile into the intestine. CT scan also important sometimes to assess the liver and its pathology. So this is in brief the different type of jaundice: the prehepatic, the hepatic, and the obstructive jaundice, and its diagnosis and assessment. Thank you very much.